everyone. Here is Dr. Guo Hongzhang from Department of Pathology, Shantou University Medical College. Today we are going to continue with the study of tumor. We have already covered the pathological terms and concepts, such as growth rate, invasion, and the metastasis of tumor. Clinically, the patient should talk with his or her doctor more about the tumor, how it relates to the treatment and the prognosis. Like here, the patient found a skin ulcer 6 years ago. The doctor told him that this ulcer was a tumor. Therefore, the patient was worried about the prognosis. To help this patient, we should know how to classify tumor from the following aspects: behavior of tumor, malignant or benign, histology of tumor, grading, extent of tumor, staging. We will further discuss the basic terms associated with tumor, features used to distinguish the benign from malignant tumor. There are 3 fundamental features by which most benign and malignant tumors can be distinguished: differentiation, neoplasia, local invasion, and metastasis. First, differentiation refers to the extent to which tumor resemble their parenchymal cell of origin, both morphological and functionally. Tumors composed of undifferentiated cells are said to be anaplastic, a feature that is a visible indicator of malignancy. The term anaplasia literally means backward formation, implying differentiation, or lost the structure and functional differentiation of normal cells. Where differentiated tumor cells are likely to retain the functional capacity of their normal counterparts, whereas anaplastic tumor cells are much less likely to have specialized functional activity. Anaplastic cells often display the following morphological features: pleomorphism, nuclear abnormalities, tumor giant cells, atypical mitosis, loss of palate. Anaplastic cells generally have hypochromatic, prominent nuclei and a nucleus to cytoplasm size ratio that approach 1:1. There is increased mitotic activity. In general, benign tumors are composed of well-differentiated cells that closely resemble their normal counterparts. By contrast, malignant tumors exhibit a wide range of parenchymal cell differentiation. Most exhibit morphological alterations that betray their malignant nature. Local invasion is the second fundamental feature. Most benign tumor closed or cohesive expansile mass that remained organized to their site of origin. A malignant tumor is accompanied by progressive infiltrating, invasion, and destruction of surrounding tissues, other than the development of metastasis. Invasiveness is the feature that most reliably distinguishes malignant tumors from benign ones. Let's compare the colon adenoma and the adenocarcinoma. The former glandular tumor is seen projecting into the chronic lumen. The polyp is attached to the mucosa by a distinct stalk. However, in colon adenocarcinoma, the cancer cells are invasive through the musculatus propria into the polyclonic fat. The invasive components of those tumors elicit a strong stroma dermoplastic response, which is responsible for their characteristic form consistency. Third, the invasiveness of tumor permits them to penetrate into blood vessels, lymphatics, and body cavities, providing opportunity for spread. Metastasis is thus the outstanding characteristics of malignancy. In general, the more anaplastic the primary tumor, the more likely is the metastatic spread. Let's look at the colon adenocarcinoma again. Glandular structure similar to primary adenocarcinoma was found in the lymph node, indicate metastatic. Besides the above three fundamental characteristics, there are three other features that also could be referenced to distinguish benign from malignant tumor, including growth rate, necrosis, and recurrence. The rate of growth of malignant tumors correlates in general with their level of differentiation. In other words, rapid growing tumor tends to be poorly differentiated. Benign tumor usually enlarged very slowly, while malignant tumor grow more quickly in size. To put this in a more specific perspective, it may take months or years for a benign tumor to change significantly in size, while malignant tumor can grow appreciably in just a few weeks. Malignant tumor stimulate marked angiogenesis, which ensure adequate tumor nutrition and promotes vascular invasion and metastasis. However, because of the rapid growth rate of many malignant tumors, areas of necrosis are often found within this tumor. Tumor hypoxia is an important feature of aggressive malignant tumor, and as a morphological marker, necrosis is known to be associated with malignancy. If a tumor returned after surgery, it is called a recurrence. Some tumors can be removed by surgery with little risk of coming back. This type of tumor is often benign. However, malignant tumor may have a higher risk of recurrence. To summarize, benign and malignant tumors can be distinguished from one another based on the degree of differentiation, local invasion, and distant metastasis. Benign tumors resemble this tissue of orange and are well differentiated. Malignant tumors are poorly or completely undifferentiated. Benign tumors are well circumscribed and have a capsule. Malignant tumors are poorly defined and invade the surrounding normal tissue. Benign tumors remains localized to the site of orange, whereas malignant tumors locally invasive and metastasize to distinct sites. If the tumor has been diagnosed as malignant, methods to qualify its probable clinical aggressiveness and its apparent extent and spread in the individual patient are necessary for arriving at an accurate prognosis and for comparing end results of various treatment protocols. Grading of a malignant tumor is based on degree of differentiation of the tumor cells. Grading schemes have evolved for each type of malignancy, but generally it's close to categories: low grade and high grade. High grade means poor differentiation with more progression. Furthermore, the stage of malignant tumor is based on the size of the primary lesion, its extent of spread to regional lymph nodes, and the presence or absence of blood-borne metastasis. The major staining system currently in use is the American Joint Committee on Cancer Staging. This system uses a classification called the TNM system. TNM staging varies for specific forms of malignant tumor, but they are general principle. T refers to the primary tumor. T0 is used to indicate an in situ malignant tumor. Score of T1, T2, and so on refers to the primary tumor size, extension, or both. Higher value means a greater magnitude of the malignant lesion. N indicates regional lymph nodes involvement. N scores are based on whether there is malignant tumor in the nearby lymph nodes and the number of regions of nodes involved. N0 score means there are no malignant tumors is found in the lymph nodes. N1, N2, and N3 score are based on the number of nodes or nodal groups containing malignant tumor. Higher score suggests a greater extension of the malignant tumor. M denotes metastasis. M means there is no cancer in distant site, while M1 represents cancer found in distant sites. Cancer staging is one of the factors the doctor used to assess prognosis. Very importantly, the cancer stage is also one factor that helps doctors to plan the best treatments for patients with malignant tumors. In modern practice, grading and staging of tumors are being supplemented by molecular characterization, such as hormone receptor and human epidermal growth factor receptor 2 expression, which are important factors in selecting appropriate therapeutic strategy for patients with breast carcinoma. To summarize, benign tumors are well differentiated and stay localized in one place, while malignant tumors invade surrounding tissues and in most cases can metastasize to distant organs. The grading and staging of malignant tumor is based on the differentiation and the spread. With tumor, nothing is more important to the patient than being told it's benign. They are the reference, and thank you for your attention.